For decades, COPD care changed slowly, but with the arrival of biologics and a better understanding of inflammatory endotypes, pulmonology is undergoing its most significant evolution in years. Now more than ever, eosinophils, symptom patterns, and treatable traits, not labels, are guiding therapy, and the traditional boundaries between asthma and COPD may be fading. The result is a new approach to airway disease, one that prioritizes inflammation, outcomes, and long-term stability. Here's how precision medicine transformed chronic airway disease in 2025.
Well, biologics for asthma has been pretty much well studied and has a assured place in care of patients with severe persistent asthma. It's been somewhat more of a struggle in patients with COPD, a lot to do with the difference in the diseases in terms of age group, factors, how the lung is altered in patients with COPD is markedly different than in patients with asthma because there's a fair amount of structural changes that occur with smoke or environmental pollutant exposure to the lung that can result in emphysema or airways disease or pulmonary fibrosis, other abnormalities. Plus, the age of the patient population is older. There's a significant impact of comorbidities that can affect the patient with COPD. So we've had more failures than success over the last 12 years since biologics have been looked at with COPD. More recent success with the approvals of dupilumab and mepolizumab in patients with COPD, but it reminds us that we still have a lot to learn in that benralizumab, again, just recently failed in looking at the COPD population, although it's had significant success in patients with asthma, in patients with nasal polyps and chronic rhinosinusitis. So, it's humbling to see that we've learned a lot and we've come a long way with biologics, but there's still a lot more that we need to learn in the COPD patient population, mainly selecting the right patient for the right therapy.
In the past, they've called these patients like COPD overlaps, and there's controversy there as well. But I think a lot of it comes to like the history. You talk to these patients, and they don't really present as much with an asthma phenotype. They seem like COPD patients that have some other ongoing inflammation on top of it. And I think that's why it's good to have real world data, just because this is what a clinician is going to have to decide when they see a patient. Is this asthma? Is this COPD? Is this COPD with overlap? And I guess the question is, does it really matter if they are phenotypically behaving more like COPD? They failed all kind of standard of care treatments. They have eosinophilia, and they're still having frequent exacerbations.
There's a movement called, treatable traits in lung disease that rather than putting people in those boxes of asthma and COPD, that, look for type 2 inflammation. Classically, we've had to demonstrate reversibility or airway hyperreactivity to diagnose asthma. Those diagnostic tools are difficult, not available in a lot of settings, and the lines between the two diagnoses are getting blurrier as more data comes out. And so, I think there may be changes in these sort of diagnostic boxes. It's a complicated issue because it impacts sort of how the criteria for designing clinical trials and drug approvals. So it's not an easy issue to really shift on, but there's definitely movement in those spaces.